So, good morning, good evening, good afternoon, wherever you are in the world. Welcome to our fifth Friday lecture series. Today we're going to talk about mental health systems in elite sports. And, well, maybe not completely objective, but I do think we have an amazing program, as you can see here. We got athletes talking about their own experiences. We got researchers, psychologists talking about the new IOC consensus statement, and we got some case studies as well. And to top that up, we got some practical screening tools that we will present with you. My partner in crime today in organizing this is Vincent Goetebarge. I thank him a lot for getting this amazing group of speakers together. I also thank all the speakers for their willingness and also guts to be here and talk about mental health issues and mental symptoms in elite sports and how they dealt with it and how we as clinicians and researchers should do a better job and taking care of them. So let me get Vincent, Abhinav, and Caroline here as well. They're first up in our session today. I will leave the page. And I'll leave it to you, Vincent.
Yes, thanks. Hi, everyone. Obviously, it's a pleasure to start our session with two former elite athletes. We have Caroline Johnson, former elite professional footballer from Sweden, and Abhinav Bindra, Olympic champion from India. Hi, Caroline. Hi, Abhinav. Thanks. For your time. It's nice to have you here, and obviously we have only 25 minutes to reflect on such an important health domain in elite sport. First question perhaps to you, to both for the audience. Perhaps you can give us a short summary of your sport career, please. Caroline, perhaps you can kick off.
Hi, everybody. I'm a former, but most people call me old, football goalkeeper. My sport career has been from the countryside in Sweden to play in the world team of FIFA. And I've participated in 3 Olympics and the World Cup and the European Championship. Both European Championship and the World Cup, I lost on a golden goal in the final, which means as a goalkeeper, you are the last one that can do anything about it. So that is kind of tough mentally to actually deal with. But I've had a great career in sport, and I also combined my last time in sport with education. So we have a program in Sweden that makes it doable to combine elite sport and studies. So I started to become a psychologist in the end of my career as a football player. I also played abroad in different countries, especially US. Short, but intense.
Abhinav?
Hello, everybody. I'm Abhinav Bindra. I'm a former sport shooting athlete. I had a long career, which lasted about 22 years. These 22 years were full of ups and downs, a lot of failures, some success. I won the Olympic gold medal in the year 2008. I was also world champion. But all in all, looking back at my career, which I can do now because I have sort of exited my investment of sorts. I look back at my career with extreme amount of fondness. Sport has been my greatest teacher in life. But more than a few medals which hang on my wall at home, the most important thing is the journey that I had, the relationships that I built, and the memories that I will live on with. So sport has been a great influence of my life in the past, and although I am not so connected to sport, but I use the learnings from sport in my day-to-day life. And whenever I have a tough moment in life currently, I look back at my sporting career and see how I would have handled a certain situation, and I always continue to draw inspiration from what I learned from sport.
Okay, thank you. So obviously in the next minute, we are going to travel a little bit in time. We are going to look at present, at past and the future. And my first question to you, Abhinav, about the present time, what is the connection with of you with mental health symptoms in elite sport?
Well, mental health is a topic which is very close to my heart. I obviously, during my career, had a few issues as well when I was an elite athlete. So it is something which remains very close to my heart. I've been a part of the IOC's Athletes Commission, and I'm part of the IOC's working group on mental health. So that is my connection to mental health, where we are collectively working on creating different ways to deal with this situation, because I think mental health is something which has been ignored for far too long. And I think the time is just right that we deal with this in a collective manner and work on creating enough resources to create psychologically safe environments for athletes right from the grassroots level, because that awareness of mental health for far too long has been missing. Whenever we talk about the mental aspect of sport, we've always really focused on the performance aspect of sport, which I think is a big mistake. I think personally, for far too long, I believed in the equation that a gold medal equals happiness. But frankly, that is a flawed equation to be dealing with. And I know that personally, I do know that a lot of athletes continue to believe in that equation, but primarily due to a lack of awareness, a lack of education in the mental health aspect of sport. I think the human well-being of the athlete is often ignored. And I think that the time is just right that the human well-being of the athlete is kept at the heart of high performance. This is something which I'm very passionate about, and now that I've retired as an active athlete, my real connection to sport is on this aspect, where I'm working on different projects and in different areas related to mental health.
And same question to you, Caroline. Obviously, you mentioned that you are a psychologist, so obviously you prepare that properly during your career. Can you perhaps explain us what is your daily practice with patients and with elite athletes suffering from mental health symptoms?
Yeah, I just must say I agree very much to what you're saying before, because I think there is and have been a lack of this support system for athletes throughout the history. And I see a lot of change. And what I'm doing today, I work like in three aspects, I would say. I work as a clinical psychologist within the hospital environment with only elite athletes. And we had three sessions like that in Sweden, where we have departments around the country only working with elite athletes. But that aspect of my work is when the athlete is already feeling mentally despair or in eating disorders or something more severe than what we usually call the support system to handle. So this is like a little bit over that. I would say you're screening high on different tools. So the other aspect of my work is to prevent that. So working much more proactively, and then I have two ways to do that. One is working with Vincent, for example, in the unions. So we're really trying to set the groundwork with conditions for players, athletes around the world to have a more stable and sustainable life situation. So by talking about this type of questions, by setting standards in how you should actually have your performance environment, issues like this should be on the table. And if you don't bring that up, your association or your club or whatever your connection to sport is should. So I think that is a really important part also to work with these issues, is to set that groundwork and the conditions of how the environment you are in is developing. And then the third part is education. I work a lot with psychological education. So you educate the athletes to actually see for themselves, where am I? how do I react? What can I do myself? And where could I go for help? What kind of ways do I have? So those three aspects is where I connect today with the sport. And I think we are gaining in this area, and we are working much more together. But we have a very long way to go still, because I think it's like you said, Abhinav, that still a lot of athletes as well think that if I don't focus on my career 100%, and that means don't have a double career, don't look back, don't reflect on my emotions, I should only win. And if I want that enough, I will be happy. Because that is like the main thing with an athlete's career, is to have that gold medal. And I don't agree. And I think, as you said, it's the journey and how you live your life when you're an athlete that will matter in the longer perspective. So I see a shift, but I still think we're far from it.
Yeah, I think we are on the move indeed. There is an increasing interest about the mental health of elite athletes, which was not the case 1 or 2 decades ago. So I agree with you too. And if you look back on your career, Caroline, can you explain a little bit the change, how it was difficult perhaps 20 years back, in the youth, or when you were starting your career, how it was difficult to be open about mental health issues that sooner or later occur in a career in elite sport?
I think it's also, for me, I must say I was a bit surprised. I think I come from good conditions, a family which is loving and on the countryside. And I was really surprised throughout my career how many of my teammates, especially when you surround yourself with a team, so you live with them, you travel with them, you see them in everyday life, how many of them that were struggling. And they saw that as normal. Like it wasn't, and nobody saw it as abnormal. It was like, and in one way it's great to live with people, to see this all type of different environments and how people react, because your normality of course grows, which means you can also look at yourself as more normal, even if you have strange behaviors. But still, there was a lot of people suffering, which I saw was something we could do something about, and it was never talked about.
And what did you observe? What did you observe? A different behavior, or perhaps a different physical appearance? Because you mentioned, for instance, disordered eating, or perhaps
exactly.
People.
I would say both, like eating disorders, in how we talk about tests, for example, and the weight itself as an isolated factor of actually your results. And when we were in the Olympics, we actually had tests where your weight was so important for your test results, and your test results was then linked to how much support system you could get. And in some sports, it's actually good to have a little bit of higher weight, so to speak, on the field in football, for example, but not in the test. So there was a very much, I think, a paradox where you didn't look at the individual sport. It was just an overall test. And that actually created a lot of eating disorders, or at least feelings and thoughts about eating that wasn't healthy. Then not everybody developed to an eating disorder, but it definitely an eating problem. Mm-hmm. And then you also had the situation of OCD, for example. A lot of people say, hey, yeah, that's normal in sport, you need that. Yes. But actually that's a big problem. And it also was very, very much inflecting their normal lives. So not just in your sport environment, it actually developed to transfer to different environments in life, and it became really isolating. So, and that was also kind of seen as normal. And then of course you have...
Yeah, sorry, go ahead.
Now you also have a power situation of coaches and things like that. And the relationship issues became also very special, because your self-awareness was sometimes just thrown in the basket because you were supposed to do as the coach said. And that takes away a lot of your self-esteem, I think, but also your both awareness and how you look at yourself as a person of value. And that also transfers into life. So those things I think was very normal in sport.
You spoke to relationship, obviously very important when you are performing in team sport, and I'm sure it is perhaps different within individual sport. As you, Abhinav, different dynamic, obviously different environment. Can you perhaps explain how mental health symptoms might occur in your sport? Because I guess you are training a lot on your own.
Yes, it is a very lonely sport per se, because a lot of training is done on your own, and also the competitive environment is always about competing against your own self. And I think shooting sport is a sport a lot to do with self-control, and I think a lot of times what shooting athletes in particular can make an error is that they in order to perform well, they try and suppress their emotions, and I think yes, that control is needed while competing, but it is not a sustainable way to perform. And I think when you continue to suppress emotions and you continue to bottle these emotions up, it is certainly going to have some psychological issue will definitely crop up. So I think that is one of the dangers. I think another, the mental side is also related to the physical side of sport, because I think it's a circle, and everything's interconnected. And certain shooting sports are, it's all about stillness, and it's all about keeping as stable as possible. So a lot of athletes also train a lot on the shooting range, where we're just keeping still, and the human body is really not built to stand still. The human body is really built to move, and some athletes are not able to find that balance, because they think that just training more on the shooting range is going to get them better performance, but that's not true. Shooting is actually requires a good amount of physical movement and physical skills as well, because just staying stable is a very challenging physical activity, because it's almost against nature. So finding that balance, I think, between the physical and the technical side of sport is important. And of course, the whole area about bottling up your emotions in trying to find that self-control, I think is a big red flag. I think it's about riding the wave. There will be ups and downs, but you can't just make that mistake of bottling yourself up, because it's a very meditative sort of sport. It's a very quiet sort of sport, and if you continue to bottle up emotions, then it also starts to affect your personality outside the field of play. So it is about trying to strike that balance, which sometimes is challenging, specifically in the sport of shooting.
And regardless, obviously, the sport disciplines, I think there is still a stigma and a taboo, as you mentioned, about mental health symptoms in elite sport, and we need to do more, among which education, as mentioned by Caroline. Abhinav, if we look a little bit further in the future, which kind of challenge are ahead of us in the future? What we need to tackle principally in order to take a step further?
Yes. Before going into the future, I just like to say one thing about the history of mental health. I think one of the biggest misconceptions of athletes is that they are mentally very strong people, and they are almost immune to any kind of mental health issue or mental health disorder. So I think that is a big misconception that the general public has. When they look at athletes, they say, they will not have any mental problems, and that is a big issue. I think that lack of awareness and lack of knowledge that athletes are human beings first, and humanizing the athlete, I think, needs continuous work. And I think the pandemic, the COVID-19 crisis, has been a challenge, of course, for athletes, but for the rest of the world. And I think that has opened up conversations a little bit, even in sport, because normal people are sitting in lockdowns and things like that have found it mentally very challenging. So this, I see a lot of shift in conversation, and more people involved in the whole sporting ecosystem are also accepting the fact that this is an aspect which needs to be carefully dealt with, even in the world of sport, in the world of athletes. But I think going into the future, this will be constant work. It is also about creating the right environments for athletes. It's about creating those psychologically safe environments. Because it is a high pressure sort of environment that we live in, coaches are always answerable, the support staff, their jobs are depending on it. Everybody is after a result. And that again has the potential to create unsafe environments for the whole structure. And I think just more awareness on this aspect and creating the right environment will continue to be the challenge. But I see that more and more people are acknowledging this, and once they really start believing in the aspect that athletes are human beings first, and that their human well-being has to be the priority, and if that is the priority, then the performance will automatically follow. So it's just, I just like to end by saying that this is a continuous work which needs to be done. More awareness needs to be brought in, of course, at the athlete level, but also at the leadership level of sport. Because sometimes a lot of pressure is put on into the environment, because the leadership in sport wants results. You set targets of an X amount of medals that you want to win, and that's all right. But in the process, we must not forget the whole human aspect of this whole endeavor of an athlete's journey.
Yeah, good challenges in front of us. And perhaps from a more clinical point of view, Caroline, what do you see in the future for challenge? Do we need to educate as well health professionals who are working within the environment of elite sport, or which other challenge perhaps do you see?
No, I couldn't agree more. When you're speaking, I just want to build on it, because I really think that is such an important part to educate not just the athlete, but the athlete surrounding and support system. Just the example you said about the shooting and how your physical abilities and your mental abilities is connected. And when I just teach athletes about that, it's like their shoulders goes down, because the normality of this is how we work as human beings, work with it, not against it. That type of reshaping in understanding helps a lot. But they don't even know that. So I think that combined with actually educating the support system is really, really important. But I also think when it comes to the stigma, the pandemic is definitely helping, I'm sure. And in FIFPro, we've done some research, and also in Sweden we've done, and it opens up the conversation. But what I also think will help in the future is the social movement. Athletes has also been seen as, you shouldn't care about social movement, you shouldn't care about politics, you shouldn't care about anything. You're just an athlete and you're there to perform, and you're kind of faithless except on your performance in sport. And seeing now athletes also challenging the political system, the social movement, that also makes them more human. Mm-hmm. And in that aspect, you can also look at the human being before performance. So I think that's also something that opens up for the stigma around mental health. So I think that's also going to help in the way forward. When it comes to the clinical settings, we do have a problem, and also I'm challenged a lot with, should we even have a specific area in the hospital context for only athletes? Why? So I also think building within the system of healthcare some form of understanding that the context of athletes are a bit different. And if you understand that context, you can move so much faster. But the bottom is they're human beings. So that's why we should be in the same system. And then you have context like addiction, like sport, like anxiety or borderline, or it's just like your knowledge about that area specifically that makes the process faster. So I see that as a clinical challenge, which even in Sweden we are facing, that athletes are seeing like, why would they have a special clinic or so? So it's also a challenge within the clinical system, I would say, where you see athletes that's more, as you said, more performance driven, and they should master mental health better. I think it's changing, but it's been a challenge also within the clinical setting.
Yeah. Okay, so obviously we are on the move. We are moving in the right direction, but we are not there yet, and there is many things that will consist as a challenge for the future. Thank you, Caroline. Thank you, Abhinav, for your time. I know it's time is too limited for your input, and but nevertheless, thanks for your contribution. It is very appreciated.
Thank you, Vincent, for having us. And feel free, if you have questions, just ask.
Yes, for sure. If the audience have questions for Abhinav or Caroline, we can forward this question to them. Obviously, it's not a problem at all. Thanks for that. So I think we are going to move forward to the second contribution of our session, Dr. Claudia Redden from the United States of America. Claudia is one of the co-chair of the IOC Consensus Statement on Mental Health in Elite Athletes, and she's going to present shortly an overview of the consensus statement that was published in 2019 within the British Journal of Sport Medicine.
Fortunately, we were able to accomplish that. You can see that screenshotted here. This was published in the June 2019 issue of the BJSM. As well, it turned out that we had a variety of participants in our work group, and you can see listed here, who had really subspecialty areas of focus and interest, whether that be post-traumatic stress disorder, substance use disorder, bipolar, psychosis in elite athletes. And those work group members ended up leading the charge on the publication of a separate set of more than 10 papers in the same issue of the British Journal of Sports Medicine. So specifically, papers on bipolar and psychosis in elite athletes, substance use in elite athletes, etc. So what exactly did the work group find? Starting with prevalence and risk factors of mental health symptoms and disorders in elite athletes. And I'd pose to you this question just to get you thinking, not that we're able to have interaction here because of the time difference, but you know, what would you say if you had to answer this question? And that is, compared to the general population, how common are mental health symptoms and disorders in elite athletes? Are elite athletes relatively spared? Are they disproportionately affected, or somewhere in the middle? Well, what we found was that it is difficult to say because there is great variety in the literature, population sampled, etc. But prospective studies report that mental health disorders occur in somewhere between 5 and 35% of elite athletes when you look over a period of up to 12 months. Now, Vincent Guttebarge, of course, as I think you all are familiar, has really led the charge in this sort of epidemiologic research, and it's really been just important, paramount in drawing attention to the fact that our athletes are not spared from this kind of suffering. And in fact, when you look at the evidence, it suggests that there are certain symptoms and disorders that are even more common in elite athletes relative to the general population, specifically eating disorders, some substance use disorders. We'll get into specifics of these things in a second. ADHD, that's attention deficit hyperactivity disorder, gambling disorder, this hidden addiction that no one thinks about, and then certain sleep disorders such as sleep apnea, for example, in athletes who tend toward higher body mass index. At the same time, there are certain symptoms and disorders that are probably at least as common as in the general population, perhaps not disproportionately more common, but at least as common, including other sleep conditions such as insufficient sleep, circadian dysregulation, insomnia disorder, depression, anxiety across the spectrum of anxiety-related conditions, and post-traumatic stress disorder. When we looked at really specifically what are the sport-related risk factors for mental health symptoms and disorders in elite athletes, a number popped up. Severe musculoskeletal injuries, multiple surgeries, decreased sport performance, so slumping, choking, maladaptive perfectionism in sport, perfectionism being such a fine line, sometimes advantageous, but if things don't go right, it can really create troubles. Peak training loads, times of peak intensity of training, and then many more sport-specific risk factors in given sports for certain mental health disorders, and we'll look at that too. So now just a brief word on management, and specifically looking at general approaches to management. I'm not going to get into the weeds given the time limitations in terms of, what specific medication is the number 1, 2, and 3 choice for depression in athletes, but just some general approaches. Starting with psychotherapy, because in many situations, this is the treatment of choice for high-level athletes for a number of reasons. Medications tend to have side effects. Athletes worry appropriately about side effects and their impact on performance. There are a couple of caveats that are important to keep in mind. Number one, we should recommend psychotherapy plus pharmacologic, i.e. medication therapy, when indicated, particularly for moderate to severe symptoms. If someone has a condition like bipolar disorder or a psychotic disorder, we really can't compromise that pharmacologic aspect. And additionally, we shouldn't ignore the fact that substance use problems may be present. Sometimes it's tempting to, sort of not address those problems. We don't want to offend our patient. They may have zero insight into the fact that it's an issue, and so we don't want to, push it with emphasizing the need for that. But in other words, my point of this slide here is we shouldn't compromise on full and effective evidence-based treatment if more than just routine psychotherapy is needed. I as well here have screenshotted a Stillman et al. Paper. This is one of those aforementioned subspecialty papers published in the June 2019 BJSM. And this one was specifically taking a deep dive into the topic of psychotherapy for elite athletes. What about pharmacology? So when it's needed, there are at least 4 important considerations that are relevant for elite athletes. Number one, we really do have to think about the potential negative impact on athletic performance, so that if I'm slowing down a 100-meter dasher's time by 1/100th of a second, that could be the difference between Olympic gold and silver, between a big payday and not. It really does matter, even if that's not the kind of thing that matters to a member of the general population. Any good, sports psychiatrist really is going to have a fine understanding and appreciation of that. Number 2 and 3, these are to be distinguished, and that is we have to think about the potential therapeutic performance-enhancing effects versus the potential non-therapeutic performance-enhancing effects. we hope to have therapeutic performance enhancing effects. That is, if someone's sport performance is being limited by the fact that they're severely anxious, panicky, or so depressed they can't even practice anymore, then hopefully treating them with a selective serotonin reuptake inhibitor, antidepressant, anti-anxiety medication is going to help them feel sufficiently better that their performance gets better in sport. And that's fair, that's acceptable, that's what we want to see. Versus the third bullet point, which is the unfair ergogenic effects. Now, in the world of psychiatry, the class of medications that really has evidence showing the potential for ergogenesis is the stimulant class of medications. Those are the medications typically used for ADHD. For that reason, they're generally prohibited by the World Anti-Doping Agency and sport-specific federations. And then finally, potential safety risks. So some medications may have seemingly minor implications for cardiac functioning. Maybe they raise blood pressure a little bit. Maybe they slightly do something like increase the QTC interval if you look at an athlete's EKG when they're taking that medication. And that may not matter to you or me if we're not high-level athletes, but it could be a potential significant safety risk in someone who's a high-level athlete pushing themselves to extreme intensities. Similarly, there are some medications such as lithium when used for bipolar disorder that really has a small, safe range of tolerability and effectiveness. In terms of looking at the blood level of that medication, the blood level has to be monitored very closely. If an athlete were to take that medication, and they do, but in those instances when they do, we really have to carefully monitor those blood levels because the littlest bit of dehydration, perhaps sweating when you're exercising in hot environments, can potentially really dangerously change those blood levels for an athlete. So with that, let's dive in then to some specific mental health symptoms and disorders. We're going to start with something that is, of great concern to a number of athletes, and that's the issue of sleep. Starting with insomnia, let's look at this 2015 study that we highlighted in our findings that looked at Olympians and their report of insomnia symptoms. Now, unfortunately, you can see somewhere between half and 3/4 of Olympians do report insomnia. This is defined as a persistent difficulty initiating or maintaining sleep at least 3 nights per week for at least 3 months. Importantly, in the context of adequate sleep opportunity and accompanied by daytime impairments. Suffice it to say, our high-level athletes, who in fact probably have higher sleep needs than non-high-level athletes, are really suffering with this. Another sleep problem, unsurprisingly, is circadian dysregulation, defined as misalignment between the individual's sleep-wake pattern and the desired pattern. So maybe they need to be up super early for their morning rowing practice, as in 4 a.m., but in fact, they're a night owl. It's really hard for them to go to bed at a decent hour. And so the fact that they have to be up at 4 a.m. is really problematic. It is a common issue in elite athletes for a number of reasons. Frequent travel across time zones can really make things difficult. That timing of sport training, as already alluded to. And then importantly, because of an athlete's chronotype, meaning the degree to which they're naturally a morning or an evening person, the timing of their training or competitions even may not line up with their personal time of peak performance. They may do better, if they have time trials or competitions in the evening, but if those competitions or time trials are happening in the morning, they're really not going to be able to show their best self in sport. So this has just been a highlighting of some of the sleep problems we see. We'll move on then to depression. And there's a big meta-analysis by Paul Gorsinski from the UK in 2017, which found that the prevalence of depressive symptoms in elite athletes equaled that in the general population. And this, unfortunately came as a surprise to a lot of people who expressed shock at the finding. Again, that sort of public perception that athletes must be relatively spared from this. They live such a great life. Look at how strong they are on the outside, etc. Clearly, they're not. There were some nuances within that general finding, both from Gorsinski and others in the field. Specifically, female athletes twice as likely to report depressive symptoms, not uncommon from the general population. And not all sports are the same. And so that there's an increasing threat in the literature showing that individual sport athletes are at greater risk than team athletes. That is just popping up time and time again. In American collegiate athletes, looking across a whole bunch of sports, track and field as an individual sport emerged as top of that list. And so we could, ask ourselves, why in the world is this the case? And I wish I could invite audience discussion here. But it's interesting to speculate, and some authors have, and people feel that, well, perhaps those athletes who are drawn to individual sports at baseline, independent of any eventual effect of sport on their mental health, tend to be more sort of anxious, internalizing, perfectionistic folks who are just more predisposed to anxiety or depression. Anyways, maybe there's something about the fact that if you lose, quote unquote, lose as an individual athlete in your sport, there's less of an ability to disperse the psychological blame for that loss. The individual athlete takes full blame. No one's at fault but me. I'm the one who lost out there. Moreover, in individual sports, there typically is one winner and the rest are quote unquote losers, versus in team sports, half of the athletes are typically winning the competition. So what about anxiety? Next big category here. So there's not nearly as much research on anxiety compared to depression, but what we found was that the rates of generalized anxiety disorder, social anxiety disorder, obsessive compulsive disorder, and panic disorder all appear to approximate those in the general population. Again, some nuanced findings, specifically subpopulations of athletes at greater risk for anxiety are those who report being dissatisfied with their career. That's no big surprise, but I think these are the important things that are important to keep in mind when you're thinking about future research protocols, when you're thinking about the individual clinician sitting with the individual athlete who is reporting things like, I'm really not happy in my sport. Female identified, younger athletes, and musculoskeletal injury. Important clinical pearls here, and that is we have to distinguish anxiety disorders that are sort of overarching and impacting the athlete in every facet of their life, from sole performance anxiety, wherein the athlete is anxious only immediately before the competition or during the competition. It's not to say the latter isn't problematic, and certainly generalized anxiety disorders can coexist with performance anxiety, but there are real treatment differences in terms of if you're going to give a medication, what sort of psychotherapy you need, et cetera. As well as a common thing that pops up, even in my clinical practice, is referrals for what may look like anxious, obsessive, compulsive disorder tendencies. But if these are superstitious rituals, such as, really proscribed routines immediately before competition, you have to wear certain clothes, you have to go through certain routines of how you serve the tennis ball, etc. That's not a problem. If it's not causing dysfunction in the athlete's life, it helps them gain some semblance of control over otherwise what can feel like an unpredictable situation, and that's okay. That said, we should, take a deeper look to make sure that isn't simply part and parcel of a larger OCD package. Post-traumatic stress disorder and related disorders, again, yet another that we featured in a subspecialty review paper in that June 2019 issue of the BJSM, led up by Cindy Miller-Aaron. And what did we find? Well, athletes may encounter traumatic experiences both within and outside of sport. Within sport, these are things like sports injuries that I think historically people did not appreciate as potentially traumatic events. Because for the non-athlete, the idea of getting an injury may not seem traumatic. It may not seem all-encompassing, life-altering. But for the athlete, whose identity may be solely tied up in sport, who may now have their entire, identity, not to mention their livelihoods, taken away from them, this is a big deal. And a PTSD-like picture, if not full PTSD, can emerge. And where the evidence has particularly been focusing is musculoskeletal injury and definitely concussion as being associated with PTSD symptoms. I wanted to highlight PTSD's specific negative impact on performance because it's so interesting and intuitive how this could happen. And there is, in fact, some research on it. So the athlete who has PTSD from a sport-related injury may end up avoiding rehab or other, exercises or sport circumstances that remind them of the traumatic injury. And if they can't get back out on the court, on the practice field, et cetera, because that's where the injury happened, it's obviously going to have, dire implications for their ability to get back into sport. They may have this inhibited effort where, for example, they're holding themselves back as they jump over the hurdle, which they had tripped on and injured themselves severely on. And perversely, that actually increases their risk of re-injury, not that they consciously realize that, but obviously there's going to be a negative impact on performance there too. Let's look at eating disorders. Oh, so painfully common in my practice and the practice of really most sports psychiatrists. The prevalence across the board, really big range depending on the study you look at and the type of sports studied, but 6 to 45% in females, 0 to 19% in males. Elite athletes even more commonly meet criteria for disordered eating than for a full-blown DSM-5 diagnosable or ICD diagnosable eating disorder. So clinically and research-wise, we really do have to dig further into, okay, even if you don't have the requisite frequency of binge purge per week or per month, are you doing those kinds of things occasionally in a way that's a red flag for potential ultimate development of an eating disorder? And in fact, we do know something about risk factors for eating disorders in elite and all athletes. So weight sensitive sports, big risks. So those with weight classes like rowing and wrestling, those that may be aesthetically judged, such as gymnastics, swimming, and diving, and gravitational sports in which lower body fat may be advantageous, such as distance running, cycling, or swimming. If your sport has team weigh-ins, if there's sport-specific training before the body's fully mature, so an athlete is pegged as a gymnast, and their family puts tons of time, effort, resources, money into their development as a gymnast. And then lo and behold, they go through puberty and they don't have the body type conducive to participation in that sport anymore. There can be a sense and a pressure that they have to do whatever it takes to maintain the required body type. And unsurprisingly, then eating disorders can emerge. Performance pressure and injuries are other risk factors. Moving on to attention deficit hyperactivity disorder, a focus of Dr. Doug Han from South Korea in this review from June 2019. And what we found is that ADHD may in fact be more common than in the general population when you look at athletes, since individuals with ADHD may be drawn to sport due to the positive reinforcing effects of physical activity. Now, we need hugely more research in this area. These are preliminary findings. Importantly, sport-related hyperactivity, which is normal, normative, expected in so many athletes, should be distinguished from diagnosable ADHD because we surely don't want to be in the business of over-pathologizing behaviors that are normal and helpful and adaptive in athletes. Here's an interesting research thread, and that's the association between ADHD and concussion, with some suggestion that ADHD may be associated with prolonged recovery following sport-related concussion. Perhaps that makes sense. Some of the symptoms of ADHD look an awful lot like the cognitive clouding you see after a concussion, but we don't know the details of that interaction and if in fact it's real. Bipolar and psychotic disorders, an area headed up by Dr. Alan Curry, a psychiatrist in UK, talk about areas understudied in high-level athletes. If any of you can contribute to the world's literature on this topic, that would be most welcome. They have not been thoroughly studied, though there have been prominent cases, such as Susie Favor Hamilton, a well-known Olympic distance runner, that have been reported. But we simply don't know the prevalence. Importantly, though, both disorders show a peak age of onset coincident with the usual age of peak sporting performance. So any of us working, practicing, or researching in the field do need to be aware of this potential. It's complicated to make this diagnosis because substances that may be used by athletes, such as stimulants, cannabinoids, glucocorticoids, can cause or perpetuate mood or psychotic symptoms. So we really have to figure out, is this a primary bipolar or psychotic disorder? Is it substance induced? And then there's this really fascinating line of research. Please do look at studying this further as well. We need more data on the fact that anything that's really antidepressant can perpetuate mania in someone who has bipolar disorder. We know vigorous exercise is powerfully antidepressant. And so there's starting to be some threads of research that show that vigorous exercise may exacerbate mania in patients who have bipolar disorder. And so what does that mean for athletes with bipolar disorder? I mean, how does that supercharge their life and their involvement in sport? And how does their involvement in sport mean that they're at even greater risk for destabilization of their mood just because of all the intense exercise in which they do participate? Moving on to sport-related concussion. So just a word on this because I'd be remiss if I didn't include it. And suffice it to say that changes in mood, emotions, and behavior are quite common following sport-related concussion. If you look at the SCAT-5, screenshotted here, the symptoms listed very clearly overlap with those attributable to anxiety and depression. So things like irritability, sadness, nervous or anxious, trouble falling asleep. I feel like I'm reading the criteria for generalized anxiety disorder or major depressive disorder. So concussion is a neuropsychiatric syndrome. It has to be on our radars. Substance use and use disorder is obviously a huge topic covered by Dave McDuff, spans ergogenic performance-enhancing substances all the way to recreational. And what we know is that the substances may be used for a variety of purposes: social, recreational, self-treatment to boost performance. The most commonly used substances in elite athletes are alcohol, cannabis, nicotine, and prescribed opioids and stimulants. But fortunately, athletes use all of those at lower rates than non-athletes in general. In contrast, athletes appear to use or misuse binge alcohol specifically, oral tobacco specifically, non-prescription opioids, and androgenic anabolic steroids at greater levels than non-athletes, and especially that's the case in power and collision sports. Gambling disorder, the hidden addiction I alluded to at the outset, a topic covered by perhaps the world's foremost expert on it when it comes to athletes, Jeff Derevensky in Canada. What we know is even in the US collegiate sports system where there are specific prohibitions against gambling, as you can see by the screenshotted ad here, it happens up to 4% of the time. When you look at professional athletes where there aren't those prohibitions necessarily, up to 57% report participating in gambling during the past year, with over 8% saying it was a problem for me. Another behavioral addiction, if you will, not necessarily an official DSM-5 diagnosis, is exercise addiction. It's increasingly well described, and obviously for intuitive reasons can be difficult to sort out when this is a problem in an athlete versus when they're just engaging in normative expected high levels of activity. Really, where it becomes a problem are when you see things that are analogous to the criteria used to diagnose substance use disorders. So the athlete needs more and more exercise, to perceive the same benefit from it or to satisfy their cravings from it. Severe withdrawal symptoms, if you will, if they can't exercise. They keep exercising even though they're horribly injured, etc. So with that whirlwind tour, let me offer some concluding statements. Elite athletes suffer from mental health symptoms and disorders just as anyone else, though with nuanced epidemiology unique to this population. The IOC has truly committed, I believe this, to improve the mental health of elite athletes. And mental health is an integral dimension of elite athlete well-being and performance and cannot or should not be separated from physical health. With that, I thank you so much for your time and attention, and I wish you a good day.
So that was Claudia Reardon. Sorry for the few hiccups we had technically. She had to pre-record her video because of time differences. The same goes for next speaker, Dr. Margot Mountjoy. She's a retired artistic swimmer, has an extensive CV with multiple high-profile leadership roles in FINA and the IOC. And next to being a great person, she's also an inspiring role model when it comes to the clinic as well as research, where it concerns mental health and female athlete health as well. So let me start this up for you. 1 second. Do like this. Here we go.
Hello, everybody. My name is Margot Mountjoy, and I'm a clinician scientist from Canada. I thank Vincent for inviting me today to speak with you on the prevention, creating a healthy athlete environment for mental health. I'm sorry that I can't be with you in person because of a pandemic, but also through Zoom because of time zone restrictions. Nonetheless, I'm grateful for the opportunity to share some thoughts with you today. I'd like to make it clear that I have no financial conflict of interest at all at this topic. However, I am a member of several international sport organizations that I will declare as listed on this slide. And before I start into talking about mental health and cultures, I want to draw to your attention this HBO documentary by Michael Phelps and 9 other American Olympians that talks very distinctly about the culture within U.S. Olympic Committee and U.S. sports, in particular as it pertains to mental health. And I think if you have not had an opportunity to watch this HBO documentary, I encourage you to gain access and watch it, because it really exemplifies some of the principles that I'm going to talk to today from the athlete voice, from the athlete perspective. And I think there's a lot that we can learn from listening to our athletes and having the athlete voice front and center. So there's many quotes from this HBO documentary, but one of them that spoke very much to me was this one of Michael Phelps's. I don't think anybody really cared to help us. I don't think they jumped in to ask us if we were okay. As long as we were performing, I don't think anything else mattered. That's disturbing to me. Our athletes are human beings and individuals with rights, and one of those rights is to a healthy environment. Here's another Olympian, Lola Jones. I don't think they're maliciously ignoring our well-being. I just don't know that they realize it's like a full crisis yet. How many more Olympians, dead Olympians, do they need before they realize there might be an epidemic here? I think this one is also very true, because I don't honestly believe that sport organizations don't care about their athletes. I wonder if perhaps it's not a malicious ignoring as a lack of knowledge. So that certainly points out another point that I think we have a role in making sure that our sport environment for our athletes is healthy, so that they can maintain good physical as well as mental health for performance as well as for well-being. Really worth looking at. Please look it up. I know it was certainly quite a watch, let's say, for me. I know many of these athletes, and it was a difficult watch, but I think one that we all should be engaged with. So what about the importance of sport culture for mental health? Well, I'm going to quote from the IOC Consensus on Mental Health in Elite Athletes, Claudia Reardon et al. So in quotes, optimize environments to which all athletes train and compete. This sport culture is very important to ensure healthy mental health. And again, a second quote, create an environment that supports mental wellness and mental health seeking. So this is an important thing that we should strive for in order to improve athletes' mental well-being. One of the important things we should be looking at is the culture in which our athletes train and compete, as these environments may actually be toxic. And that's my talk today, is talking about toxic sport environments. What are they? Why? And what can we do about it? So in another 2 papers here, Reardon Sports Med, that's the consensus statement, but in another paper by Lancaster, looking at risk factors for depression in athletes, did identify environmental factors such as poor quality relationships within the sport environment and lack of social support. Let's also look at other environmental influences on mental health. If we look at the harassment and abuse literature, and this particular diagram is from the IOC consensus that talks about the culture of discriminations, the culture of discriminations based on discriminations against sex, gender, ethnicity. I mean, the list is here. You can read it. There's many reasons why there's power differentials and a toxic culture based on these discriminations that eventually lead to harassment abuse, that lead to impacts of mental health for our athletes. Now, not all athletes have mental health repercussions from harassment abuse, but the majority do who experience this. And they may be anxiety, depression, suicide, OCD, drug addictions, etc. So that you can see that the harassment, abuse, and the impacts of it are really rooted in a culture that's toxic, a culture that has discriminations that are allowed to proliferate and prolongate that leads to this. So again, another example that the environment itself is very important and integral to ensuring athlete health and well-being, including their mental health. So let's talk about some toxic cultures in sport. What are some examples and what can we learn from them? Well, I'll start off by looking in my own backyard, and there's been a recent survey, 2019, by Gretchen Kerr and her team from the University of Toronto that surveyed 1,001 current and former Canadian national athletes from 60 different sports across cultures, and found that 60% had experienced psychological harmful behavior, 20% sexual harmful behavior, and 14% physically harmful behavior. Now, the reasons for this are not identified, but suffice it to say that this has been a wake-up call within Canada and Canadian sport to address the environments of our daily training environment and competitive environments for our elite athletes. This is not okay. Here's another toxic culture, and this is a culture in one that believes that win at all costs is the attitude. And with this attitude comes risk. So here's an example of the Nike Oregon project. This has been in the media that Mary Kane, an athlete under coach Alberto Salazar, alleged that he was harassing and abusing her, which led to all kinds of mental health as well as physical secondary impacts, including the development of REDS, stress fractures, eating disorders, low bone mineral density, as well as mental health sequelae. So this, what we can learn from this is that it's a win at all costs attitude of this sport organization that really held a damaging effect on the athletes, or at least this athlete in particular, and for which Alberto Salazar subsequently has apologized in the media, in the public domain, for his behaviors. Another part of our sport culture that can be very damaging to the mental health of our athletes is the exploitation component through the media and business interests of sports. So again, it's an American-focused quote. This is from Lauren Fleshfish, who's also involved with the Nike Oregon project. And I quote, America loves a good child prodigy, and businesses are ready and waiting to exploit the story, especially when it comes to girls. And when you have good girls, these girls are good at following directions and they're good to the point of excelling, that's when you'll find a system that's happy to take them, and it's ripe with abuse. So this culture of exploitation for media's purposes and for business purposes that puts the athlete as a commodity as opposed to a human being with a voice and with rights. Coaches have also been implicating in creating daily training environments that are toxic, and I will list within the National Hockey League, ice hockey. This is in the public domain. Mike Babcock has been fired for abusive behavior with the Toronto Maple Leafs. Mark Crawford has been also alleged harassment and abuse with the Chicago Blackhawks, and Daryl Suter for condoning and supporting hazing rituals in the LA Kings. And Dan Cercillo is the athlete who's brought this story forward. And so these stories, what we can learn from them is that our coaches also need some education on improving their styles to be more conducive to healthy training environments where we empower our athletes to excel and be their best and push beyond their comfort levels, as opposed to using fear, intimidation, and other kinds of styles that can be counterproductive, and in fact, not only counterproductive for performance, but damaging and potentially toxic for athlete mental health. Here's another example, and this is from Europe. This is from France and ice skating. And here's an example where there's an abuse of power. Now, there's many examples of abuse of power in sport that's caused a toxic environment with damages to athletes. But this one in particular is an example where this coach was allowed to perpetrate and abuse an athlete without the leadership putting checks in place to ensure that this activity didn't happen. So this was an ice skating story where this coach and former world bronze medal Sarah Abitbol has alleged sexual harassment and sexual abuse from her coach. And this abuse of power is another component of cultures that are conducive to mental health problems from the abuse in the sport. There may also be country cultures and traditions within sport that are beyond just a single sport or a single perpetrator. And here is one that is from July 2020, a report called "I Was Hit So Many Times I Can't Count." This came out in the summer when it would have been during the Olympic Games in Japan. But because the Olympics were postponed, and this report, the authors of the report did not feel that it was safe to delay the report release for another year. They did release it in 2020. And this report talks about the cultural practice of taibatsu. This abuse of children in Japan within the sport context is actually giving a name, and that is taibatsu. And that's where children are physically abused with punishment, hitting with a stick, hitting with the hand, yelled at, and abused as being part of their country's culture. And that is going to take a shift in this country to make the changes to support children, to give athletes a voice and their rights to a safe sporting environment. Here's another example of a toxic environment, and this environment is a sport-specific environment, not a country-specific one, but a sport-specific environment, and that is the International Weightlifting Federation. And this federation has been challenged recently with some corruption, and corruption that has touched many aspects of function of the International Weightlifting Federation, and the allegations of serious doping concerns, of which details I'm not privy to, but there has certainly been a report this year filed by Rich McLaren. Rich McLaren, I don't know if you know that name, was the man who uncovered the Russian doping scandal in Sochi 2014. So this is a Canadian lawyer who investigates international federations, sport organizations, and in his report, he says any conduct at the highest levels of a federation that permits the rule by fear, deception, and corruption to satisfy personal desires acts to the detriment of the sport's key stakeholders, the athletes. So this is an environment where athletes have been doped, and with the harassing, with the athletes having no power, where they are being doped and it's being condoned at the highest levels, is one where athletes will not have a healthy environment. I suppose no talk about toxic environments is complete without mention of the Larry Nassar and USA Gymnastics situation. And this is one where we can learn about failed leadership. And that's another component of toxic cultures. I'm sure you're familiar that USA Gymnastics has been to courts, and that there was a settlement offered to the victims of the Larry Nassar sexual abuse scandal. Larry Nassar was a physician who sexually abused young women, young gymnasts, for many years. And let's talk a little bit about this lack of leadership. If you look at this diagram, this shows a timeline in the Larry Nassar case. And the red circles with the R in it are the number of times that people had actually reported the abuse to people in positions of power, and nothing was done about it. So the first report was in 1997. It was until 10 years later and 7 more reports before finally Rachel Denhollander, who's pictured here, took it further, her abuse, and was able to make this into a federal lawsuit. And she was able to rally all of the victims and bring their victim impact statements to the trial in the United States. So this is 10 years where the abuse continued to happen, where the leadership did not respond to the allegations of abuse and listen to these young women, and could have prevented many more people from being traumatized and damaged by this sexual abuse. So this is a culture where it's very clear to say that the leadership failed to protect the athletes within their sport. And here they are. I bring this to your attention only to say that when we're talking about cultures and systems, there's actually people behind these systems. And these are some of the women during their impact statement. And here's a list of all of the women that gave their impact statements, doing 3 days, over 20 hours of video. So Melissa McCraden, she's a social scientist from the University of Toronto, has analyzed these statements, these victim impact statements. And she's done a qualitative research on this and found different themes in the athletes' victim statements. And one of the themes is psychiatric problems. And here's some of the things that she found in her analysis. Self-care is hard to manage when your soul has been scarred, is a quote that she uses. But here are some of the things she found when analyzing the victim impact statements. Fear of men, fear of medical practitioners, anxiety, panic attacks, depression, PTSD, suicide, self-harm, eating disorders, substance abuse. That is a really disturbing finding. Nearly 2/3 of the victims that gave their impact statement during the trial described significant psychiatric symptoms following their abuse. That has persisted beyond the time of the abuse. And so what happens in an athlete is in these toxic cultures doesn't go away the day they leave or the day they retire. It can be persistent, not the harassment and abuse, but the effects, the long-term effects from this toxic culture. So she sums up in a nice little diagram here, putting it together about her analysis of what happened through her review of the victim impact statements. That the athlete was highly driven. They had a desire to pursue their sport, to compete, to win. They rationalized what was happening as something that was normal, and they were influenced by their environment, and they were not given a choice. They were not given a voice, and they were silenced. Within that gymnastics community, it was known that he is the best. They did not value the athlete's voice. They did not listen to them. It was accepted what was going on by the community. And the culture, there was a militaristic, disciplined type culture. The parents were not given a voice. The girls were not given a voice. They were devalued. It was self-governed without checks and balances. So put these things together, and you have an environment, a toxic environment, where these kinds of things can happen that lead to athlete mental health challenges. So in the IOC consensus statement on harassment and abuse, 2016, it is identified that failed leadership is the cause of harassment and abuse leading to mental health problems, where you have lack of policies and procedures, lack of independent reporting, and lack of a safeguarding officer in a culture where there's high perpetrator inclination and motivation and high athlete vulnerability. And I think you can see how that diagram pertains very well to the recent story I just described on Larry Nassar, but it applies to many more within the sport, unfortunately. So to further this, a toxic culture is abuse is nurtured in a sport culture where athletes are commodified in an environment that pursues winning at all costs, where the athletes have no power and no voice, where their abuse is either accepted as the norm or it is ignored. So this, I think, is a very important statement when we are talking about toxic cultures and athlete mental. So what can be done in a toxic environment? We can implement codes of conduct. We can make sure that the leadership itself approves and buys into this. And if they don't, then they must leave and new leaders come in that actually support the premise of healthy training environments. We must educate everyone within sport and develop policies and procedures. The athletes themselves must learn and must have a voice that's valued and not commodified. We improve their networks and make sure that the personal life and athletic lives are well balanced with good team cohesion and coach and team monitoring and expectations well maintained. In systems, we should have an international sports safeguarding agency with an offender database and improving our research gap. And indeed, as I mentioned, it takes a cultural shift in many countries and sports to improve the training environment. How do we prevent it? We have political prioritization from the top. We have a mental health action plan, which includes a social media campaign to decrease stigma. We have an emergency action plan. What does the sport do? What are the steps if there's an emergency during an event? Make sure our team physicians are educated to know how to recognize, prevent, treat, and manage athlete mental health. Make sure that our coaches are educated, as well as including mental health support at our organizing committees and in our current medical committees. And finally, making sure that our policies and procedures around harassment and abuse are implemented. So our toxic sport cultures definitely are hazardous to athlete mental health. But we also know that a healthy sport culture is achievable if there's the political desire and the action and financial support to make it happen. So thank you for your attention and thank you for your action on what we've discussed today.
Great. Thank you, obviously, for the contribution of Dr. Claudia Redden and Dr. Margot Montjoy. Unfortunately, not live during our session, but our next speaker will be live in our session. Our next speaker is Professor Alan Curry. Professor Curry is sports psychiatrist in Newcastle in the UK, so involved in all the IOC activities when it comes to mental health in elite sport. Alan, good morning. Nice to have you live in the session. And obviously, the floor is yours for the next 25 minutes.
Thank you, Vincent. I'm having a little trouble getting this going. Hang on. I do apologize. Give me one more go. It's the trouble with being live, isn't it? There we go. Specific cases in elite sport. As Vincent said, and I'm very grateful to him and to our connection for the opportunity to present today. So thank you for that. But as Vincent said, I'm a psychiatrist. I have a full-time job in a mood disorders research and treatment facility in the northeast of England, and a part-time job with the English Institute of Sport, where I'm a psychiatrist on their mental health panel. I've got two cases to discuss today that are entirely fictional, so there's no confidentiality issues here, but they do illustrate a number of points about mental health conditions and how they present in athletes and how we try and support athletes to get well and to get back and playing and competing again. The first case, as I said, it's fictional, is of Sarah, who's a 26-year-old rower. She competes in single sculls events. So she's on her own in the boat with an oar on each side. For those of you who don't know about rowing, she's highly ranked, top 5 in the world. This is pre-Olympic year we're talking about, fictional case, with a clear target to get onto the podium and possibly even a sniff at a gold medal in her event. She presents just after the Olympic qualifying race, where she finishes second. And because her country only gets one boat, she's not selected. So her Olympic opportunity has gone. A few hours later, she's with her physiotherapist, who she knows well, and she confides. She's distraught, she's disappointed, and she voices some suicidal thoughts, which are always a concern. And the physiotherapist arranges the same day for her to see the team doctor who's on site. The team doctor has a consultation, and Sarah talks about how low she feels. There's a concern that actually she's been hiding depressive symptoms now for some time. A PHQ-9 is a screening instrument for depressive symptoms, and it gives you a score that rates depressive symptoms as either absent, mild, moderate, or severe. It's actually included in the SMAT, which Vincent will be telling you about shortly. Her PHQ-9 score, done by the doctor, takes her into the moderately severe level of depressive symptoms. And because of that, and because of the concerns about suicidal thinking, she's referred to a sports psychiatrist who's nearby and who's known to the team.
Sorry, Alan, to interrupt, just 1 second. Can you move your slide forward, because we are still seeing only your introductory slide.
Right. I don't know what's happened.
Yeah, so now it's a second slide.
Yeah, so when I do that, it doesn't move.
Yeah, but okay, strange. Perhaps you just have to click with your...
if I do it like that, does it move?
Yes.
Okay, well, if I just try and get the screen as big, I don't know what's happened. Okay. If I present it like this, you happy with that?
Yes, I think we can see your slide. Thank you.
Okay, so Sarah is the sculler who tries to get to the Olympics, who misses out on her qualification place, seen by the physiotherapist, describes suicidal thoughts, seen by the doctor who's concerned about how depressed she is, and is then referred to, let me just, there we go, is referred to a psychiatrist who's known to the team. The history that presents there with the psychiatrist is how tired she is. She has no energy. She lacks motivation. She feels low. Those are the core features of a depressive disorder. So we're moving here from symptoms into disorder, and that's quite an important distinction. She's tired. She lacks motivation. She feels low. She can't enjoy things, what psychiatrists and psychologists call anhedonia. Alongside that, her concentration's poor, she's not sleeping very well, and her appetite is diminished. So there are clear symptoms there suggestive of a depressive disorder. And the psychiatric examination confirms that. She appears low, she's quite unreactive and unhappy throughout an extensive consultation. Her thoughts are preoccupied, and this is common. Her thoughts are preoccupied not only by failure, but what failure means, what coming second actually means. And strong in her thoughts were the thoughts that she had let others down, that those who had invested time and energy and finances to support her, especially her family, had been let down by her performance. She did have some suicidal thoughts. They were quite non-specific. She thought the future was empty and hopeless. She'd be better off if she wasn't here. She found these thoughts very distressing, and they would come several times a day, but only momentarily. They weren't associated with any strong intent or any plans to act on them, and she often thought of her family, which was protective. The psychiatric history also picked up some background details about her past medical history. Nothing terribly significant. She had an injury, as many athletes do, but had made a full recovery, and no previous mental health concerns. There was a family history that she presented, unclear of the details, but she knew that her father had been a heavy drinker and might have been depressed at some point in the past. So something in her heritage, something in her family history there. We get interested as well in sort of pre-morbid functioning, about how people are before they develop symptoms, before they become unwell. Like many athletes, she was a driven perfectionist. Now, there's nothing wrong with being a perfectionist. It's associated with success. It's overrepresented in academic spheres as well as sporting spheres and in other areas of life. But the issue about perfectionism is when it becomes dysfunctional, and it's when you marry those two attributes, when those two attributes come together, setting high standards alongside being very self-critical. And that gives you the fertile ground for depressive symptoms to emerge and to develop. High standards and self-criticism. So you set a high standard and you just fall below that standard, and you berate yourself repeatedly and see yourself in a very negative light as a consequence. She'd also recently been overtraining, which came out in the psychiatric background. And by overtraining is very difficult to judge in a high performance sports environment, but there are some pointers that we look to. Things like training when you probably should be resting. We know that rest is necessary for the physiological adaptation of sporting excellence, and training when you should be resting, training in secret, doing extra training that's not part of the program that your coach doesn't know about. And she was doing a lot of this, a lot of extra sessions in the gym and a lot of extra endurance sessions. She would go for a run after her late morning session on the water. And there's something that's been touched on already this morning, and I've tried to capture it here. It's about the need to win. And in the early stages of a sporting career, say in adolescence, when you're enjoying your sport, when you're getting to grips with it, when you're winning regional titles and getting nationally known, success is enjoyable, it's pleasurable, it's fun, you can celebrate it. Sometimes for some athletes there comes a point when you don't enjoy that. It's more about relief that you have won. That need to win to sustain your mood, to sustain your identity, and stopping enjoying success. And she reported that. The psychiatric formulation that the psychiatrist pulled together began with this. Firstly, picking up that we're moving here from symptoms into the realm of disorder. There is a condition emerging here, a clinical condition, that the psychiatrist would have labeled a major depressive disorder. First episode, and in terms of its severity, it was moderate. And moderate's important when we come to think about treatment options in a moment. Another important thing to do, and I'm sure Vincent will cover this when we look at the SMAT, is we don't just diagnose the single condition. Many conditions are comorbid, they co-occur, and it's common, for example, to see depressive symptoms alongside maybe some substance misuse, or to see an athlete with chronic pain as a result of an injury developing some depressive symptoms. So sometimes conditions are comorbid, but there were no significant comorbidities in her case, so it seemed fairly straightforward. Psychiatrists tend to think about a formulation in terms of what might predispose an athlete to a problem, what might trigger it, what might be the precipitant, and what might be a perpetuating or a maintaining factor. And the predispositions that appeared in her case were the family history, her heritage. She had an absent father, and she elaborated on this in the consultation, an absent father who was hard to please. And a lot of her sporting performance through adolescence was in an effort to win his affection and respect. Perfectionism, and we go beyond that. Perfectionism there's nothing wrong with being a perfectionist. It's associated with success, but when you combine those two attributes of high standards and self-criticism, that's when it becomes problematic. Those were in her predisposition. Precipitants. Well, the immediate and obvious trigger was that she didn't qualify, but it wasn't just that she didn't qualify, it was how she appraised that, what that meant, the personal meaning. I'm a failure, and more especially, I have let people down. And the overtraining was a clear precipitant as well. And there's an interesting intersection between overtraining, becoming physiologically depleted, what that does to your stress hormones, to your immune system, and how that might relate to depressive symptoms. And then the final thing was the perpetuating factors. This was someone who had an empty life ahead of her because she had no plan B. There was a plan A, which was to qualify for the Olympics, to get to the Olympics, to make the final, to get onto the podium and possibly to the top of the podium, with no plan B, nothing. It was also noted that she was quite a solitary individual. She's in an individual boat in a sport that's quite individual. So she's solitary and she doesn't readily confide in others. She had a relatively underdeveloped and small social support network. Some treatment options were reviewed. The first one was rest. She's been overtraining, she's depleted, she needs a bit of a break. So there's some light exercise, but it's not described as training. So she's allowed to do a little bit and she agrees to that. Psychological treatments are reviewed. And a couple of important points here. One is it's helpful to have a range of psychological therapies available so that you can match them not only to the individual, but also to be able to deliver them in the environment of elite sport. Many of you will have heard and know about CBT, which is a strongly evidence-based treatment for depression, which is thought to be very particularly helpful for athletes. Athletes like things like agendas and targets and so on. The CBT matches that. Interpersonal psychotherapy is a particularly effective treatment for depression, and there's been a lot of recent interest in a treatment called acceptance and commitment therapy. And part of the consultation would be to discuss the elements of all of those different therapies so that we get a good match between the therapy and the athlete. Medication considerations have already been reviewed extensively by Claudia in terms of issues around, for athletes especially, tolerability, safety, and performance concerns. Specifically in relation to medication, when symptoms are at moderate severity, then antidepressant medication is an option. We would more strongly advise it if symptoms were more severe. And Claudia mentioned that point that all sports psychiatrists are aware of, and it's the need not to compromise psychopharmacology if someone really needs and would benefit from that treatment. But here we're in a situation where it's at the level of an option rather than something that is strongly advised. There's a limited evidence base for prescribing antidepressants in sport. The best evidence that we have comes from expert opinions that take an approach of individual prescribing. So knowing enough about a range of different medications so that you can match them not just to the illness, but to the athlete and the physiological and biomechanical demands on the athlete. And there's a couple of references I've given you there where some recommendations are made about treatment, considering drugs like the SSRI class, like sertraline or fluoxetine, for example. Another issue here, and one of the reasons why the team chose this particular psychiatrist, was because of their ability to join the multidisciplinary team around the needs of the athlete to support not just a treatment plan, but a recovery plan. Don't worry too much about the details on that slide. Focus on the principles of multidisciplinary working. And the three important principles are that it's athlete-centered, the athlete's in the middle of it, and all the decisions are made for the athlete, about the athlete, with the athlete involved. That there's good communication between all the professionals, between the coaching and scientific team that are part of the performance team, and the clinical, the medical team, the team doctor, the therapist, the psychiatrist. And a helpful concept here is that of a sort of inner circle of people around the athlete, those within the team, maybe a sports psychologist, maybe a nutritionist, maybe a strength and conditioning coach, maybe a technical performance coach, and an outer circle of available experts. And for an injury, that would be the best orthopedic surgeon that you know within a 50-mile radius. And in this case, it would be the best psychiatrist or clinical psychologist that you know within a 20, 30, 50-mile radius. I mentioned overtraining and depression. That's an interesting area because there's clearly symptom overlap. Claudia presented you a slide looking at the symptom overlap between concussion symptoms and depression and anxiety. There's a symptom overlap here too. Some have reported diagnostic issues, that if you see a sports medicine doctor, they will pick up on the overtraining quite readily and might diagnose an overtraining syndrome, but might miss the depressive symptoms. If you see a mainstream clinician who doesn't work in sport, they might pick up the depressive symptoms but miss the element of overtraining. So there are some diagnostic issues there. There's also an interesting issue that needs further investigation, which is how people respond to rest. The overtrained athlete will respond well to a period of rest, but the depressed athlete might not. The depressed athlete might not respond very well to being taken out of the sports environment, to having a period away from the social supports and the training that gives them structure to their daily life. And there's some interesting work going on at the moment looking at depression and immune function, and I've summarized some of it there. Immune function is temporarily suppressed by high-intensity exercise. And if you're intensely exercising for a sustained period, as many athletes do during periodized training, then you enter into a period of more enduring dysfunction, and at some point that becomes overreaching, and at some point that becomes overtraining, and immune dysfunction is associated with that. But we also see altered immune function in subtypes of depressive illness. So some people who have inflammatory markers and altered immune function are overrepresented in depressive cohorts and tend to have a poorer prognosis for the depressive illness. So those are some of the issues around Sarah. I apologize for the little glitch at the beginning and that you can't see the full slides as I intended. I have a second presentation, a little bit shorter, this one. This is a footballer. And again, it's entirely fictional. You can tell it's fictional because I always write a fictional case about footballers and introduce an ACL injury. I don't know why I always do that. Footballers get other injuries too. But Steve is a 24-year-old central defender who had a severe ACL injury a year ago and had to have reconstructive surgery. His rehabilitation, as it often is after ACL injuries, was difficult. It was prolonged. He had a couple of false starts with it, and he was out for 8 months in total. During that 8 months, he was bored, he was lacking motivation, and he began to become anxious and uncertain about his future, especially when the central defender who replaced him was starting to shine within the team. So he's getting quite worried about his place in the team, but he's now back in full training. Some of his teammates notice a change, and they notice some quite non-specific things. They notice that he's a bit more irritable and short-tempered, that he moves away from being someone who's always well-groomed and takes a great deal of care about his appearance, about his clothing, about polishing his shoes, about always being very smartly dressed. He's now less attentive to that, and he's occasionally quite uncharacteristically late for training. He was a dedicated player who was often first into the training facility in the morning, and now he's occasionally late. And they socialize together, and he drinks more than he used to, and more than the others when they're socializing, say after a training session in the afternoon. And someone close to him nudges him and prompts him to see the team doctor to have a discussion about this. The team doctor, in confidence, establishes a history like this. And it's a history of alcohol use and about 3 months of binge drinking. So discrete periods of heavy drinking. Sometimes with his teammates after training, but as we've mentioned, he drinks more than they do, and certainly more than he used to. He does this 3 or 4 times a week. He'll have 4 or 5 pints, because he's English, it's pints we drink, 4 or 5 pints of beer, and then he'll move on to some spirits, which again is very uncharacteristic for him. He'll have 2 or 3 large measures of whiskey after he's had his pints. He's getting some tolerance to this. It's beginning to have less and less of an effect, and he's beginning to get used to it, but dependence symptoms aren't reported. He's referred to a sports psychiatrist who again is known to the team and who lives and works locally. And the same history but in a little bit more detail, is established. And the gradual increase in alcohol consumption over a year, and especially the last 3 months. Similar history in terms of quantity and frequency, the tolerance that's developed. His alcohol background was really quite limited. He'd had his first drink in his mid-teens, but was far from being a regular drinker. In fact, he'd looked after himself very well because of his involvement in sport. There was a family history again. His father was a problem drinker who was a bad-tempered individual. Steve also reported that he was a shy person, that he didn't always shine in social situations, but the disinhibiting effects of alcohol allowed him to do that, and he quite liked that. There was also a history which others in the team weren't aware of, that he'd actually been in an altercation, a fight, when he'd been out one evening with some teammates and when he'd been intoxicated. And again, that search for comorbidities. There are other conditions that often go alongside an increase in alcohol use, conditions like depression, anxiety, PTSD, chronic pain, and others. And the history didn't pick up any of those comorbidities. The psychiatric examination, the mental state examination, is the highlights are listed there. He was unshaven, uncharacteristic for him. He did smell strongly of cologne, which you often see in people who are drinking. It masks the smell. His mood was reactive. He was quite engaged in the consultation. Didn't appear depressed or anxious. His speech was coherent. It wasn't slurred. He linked his drinking problem to his boredom and frustration, and his anxieties about his place in the team. He was aware of the harm that alcohol can cause, and he did want to make some changes to his behaviour, but he was afraid of admitting to the problem to the coach, for example, finding out, and afraid of his place in the team if he acknowledged it. Many of you, especially those who have a background in psychology, will be familiar with a diagram a bit like that, which illustrates a model of change. This has general application to any behavioural change, but specifically in relation to Steve, it's about changing his harmful behaviour of his alcohol consumption. Before we make a change, we're maybe in a state of pre-contemplation. We've not yet begun to think about it. Then we move helpfully to a state of contemplation, where we might be starting to think about doing something about a behaviour. Then we begin to prepare for that, to take some action, and having taken the action and changed the behaviour, the difficult task then is maintaining that change. And if we're able to maintain it, then we move out of that cycle and into something happier and healthier. And if we can't maintain it, we relapse, and then we're back at the beginning of the cycle in a pre-contemplative stage. And I've changed colour there at preparation, because that's probably where I would have put Steve, at the kind of preparation stage. Maybe there's an argument for saying that he's somewhere between preparation and action, but he's aware of the issue and he wants to do something about it. So he's moved on from contemplation to preparedness to take some action. And that's helpful, because that helps to engage him in therapy. An important element, as with Sarah, is that some kind of risk assessment is undertaken. What are the risks here? And we break that down usually into three broad groups. We think about the risk to the individual, we think about the risk to others, and we think about protective factors. Those are important. Protective factors are especially important because if a protective factor disappears, then risk can increase quickly and substantially. The risk to himself, suicide wasn't an issue. There was a risk of accidents if he was drunk. And other risks that go around that, things like sexual indiscretions if you're intoxicated, or that you might drive when you're drunk. And so the risks to self are important to think about quite broadly. There's a risk to others. He'd been involved in an assault. Someone else had got hurt. He's 24. He's a footballer. He's fit. He's strong. He's powerful. You could break someone's jaw if you got in a fight. If you're Steve and you're fit and strong. The protective factors were there. He had an understanding of what the problem was, and he was ready to make changes. A rating scale was used. This is a rating scale that very simply asks about alcohol consumption, recent alcohol consumption. Again, it's included in the SMAT. Each item is scored on a range of 0 to 4, so you get a total score of 12. And at 4 or more, it has good metrics, a good sensitivity and specificity for picking up potential problems. Steve scores 9, so he's well into the area where we would become concerned. And like Sarah, the psychiatrist constructs a formulation with a single diagnosis of alcohol use disorder that is moderate, with no significant comorbidities. So we're moving on from, again, we're able to pick up a disorder here because we have the detailed history and assessment. So it's not symptoms, it's disorder. And again, the formulation includes thinking about the predisposition, the precipitants, and the perpetuating factors. And the predisposition that was picked up here, his shyness was thought to be a bit of a predisposition, especially what happens when he has a drink and what happens to his shyness when he's had a drink. And the family history might be important too. The precipitants, he mentions the boredom, the frustration, the uncertainty, and there's an easy availability here. There is a culture within the team at least once or twice a week of going out and having an afternoon session of playing bar games and drinking after a training session, and a culture of doing that after an important match too. And the perpetuating factors, and these are often the most important when we're thinking about alcohol use disorder. Alcohol, as most of you will know, is a pleasurable thing to drink in moderate quantities, and we can quite quickly habituate to the effects of that. And it's often the perpetuating factors that are the most important and the most difficult to address. It might not take much to introduce you to alcohol, and once introduced to alcohol, you can get stuck with it. And the perpetuating factors for Steve were the disinhibiting effects, the positive impact on his social functioning, at least initially, and the development of tolerance, and therefore the need for increasing quantities. The management plan that was put together involved some sessions with a counsellor, using some motivational interviewing technique and aiming for abstinence. He was also given some information on local support groups. Pharmacological treatments, again, as with Sarah, they get considered but weren't thought to be necessary in this case. They're usually reserved for more severe problems, as we illustrated in the earlier case. So pharmacological treatments would probably only be used if there were more severe problems. For example, to manage withdrawal symptoms. And other pharmacological approaches are sometimes used. Naltrexone can be helpful because it reduces the reward effects that you get from alcohol, so it becomes a less rewarding thing to drink. So all the positive reinforcement and maintenance that comes from alcohol is removed. Excuse me. Acamprosate is a medication that's used to sustain abstinence once it's achieved. And occasionally, but it's quite an old-fashioned treatment, disulfiram is used. Disulfiram will create an unpleasant physiological reaction if you drink alcohol. So drinking alcohol, instead of becoming a pleasurable thing, becomes quite an aversive experience. And that's still occasionally used, although it's quite an old-fashioned treatment. They were all considered and discussed with Steve, but weren't necessary in his case. And that's how Steve's problem was managed and addressed. I've included some references here. These will get shared later, and some suggested readings, including if you're interested in the case studies approach to sports psychiatry problems. Many people find it a practical way of thinking about problems and how they might be addressed. It's sometimes a bit easier to read because it's more real life than reading something a bit drier like an academic review. If you're interested in the case studies approach, then I can recommend that book to you. Many thanks for your attention, and once again a final apology for the little glitch earlier. So sorry about that.
Thank you, Alan, for your contribution. Not sure whether we have any question for Alan. Evert, perhaps, do you have? Oh, yes, there is a question from a colleague from Amsterdam, Leonard Blankenfort. A psychologically safe environment requires actors in that environment with a good mental health. What about the mental disorders of coaches, trainer, team, owners, and so more? Well, Alan?
Would you like me to take that one?
Yes, please.
That is important, and it gets neglected. Claudia, in the review that she led and I was part of, listed about 15 things that were important to research. And we do need to look after the mental health of the athlete's entourage as well. It's often said that a sports coach, for example, if you list all the stressors that the athlete has, the sports coach has almost all of the same stressors. How they're judged by performance, all the traveling that they have to do, all the time they have to spend away from home and their social supports. And they probably have some of them to an even greater extent. Coaches will often talk about having the responsibility without the power. You're judged by results that actually you have less influence on than if you're on the pitch. If you're watching from the sidelines, you can't actually do a great deal about what's happening on the pitch, but you still have a lot of responsibility for what's happening there, just to give one example. So yes, coaches have many of the same stressors and sometimes even more of them.
Thank you. Thank you, Alan, for your contribution.
Thank you.
So then it's you and me, Vincent. I'd like to introduce Vincent Goetebage, one of our own in Amsterdam, a former professional football player himself. He is now one of the researchers within the Amsterdam University Medical Center, within our IOC Research Center. He's also the Chief Medical Officer at FIFPro, taking care of football players worldwide. And he's one of the leading researchers within the IOC consensus on mental health of athletes. So Vincent, the floor is yours, and I'll leave it to you.
Yes, thank you, Evert. I'm going to squeeze my presentation within the last 15 minutes. Obviously, one of the recommendations that we made within the IOC consensus statement was that there was a need to develop assessment tools in order to screen athletes for mental health symptoms and disorders. So it's what we did. Within the IOC mental health working group, we did develop an assessment and recognition tool in order to identify in early stage elite athlete suffering or likely to suffer from mental health symptoms and disorders. Well, today I'm going to focus on these tools and not on the process of the development of these tools. And if you are interested to read a little bit more information about the process that we did conduct in order to come to these tools, then I refer to you to the article that was published in September within the British Journal of Sport Medicine. And within the manuscript, you can also find the developed tools. So we did develop the IOC Sport Mental Health Assessment Tool and the Sport Mental Health Recognition Tool. Well, for those that are familiar with the SCAT, the Sport Concussion Assessment Tool, then you recognize a little bit the distinction between the assessment tool and the recognition tool. The assessment tool is developed principally for sport medicine physicians and other licensed and registered health professionals. By contrast, the recognition tool is obviously available for athlete and all members of the athlete entourage. So if we look first at the recognition tool, it's quite a straightforward tool. It's one page of information. It can be used by athlete coaches and obviously family members and all other members within the athlete entourage that are perhaps not medically educated. The recognition tool is developed in three main sections. The first section presents some information about what is mental health symptoms and disorders, and we divided this section in thoughts, feelings, action, and physical change. The second section, it's not easy to miss it. It's the red flags in the red box. And obviously, one of the red flags where you have to take immediate action is when an athlete is talking about doing self-harm or harming other within his or her entourage. And the last section is actually what you have to do when you are exposed to an athlete who is reporting some mental health symptoms, but it also explains what you have to do yourself if you are reporting some mental health symptoms. So it's quite straightforward, one page, it's a recognition tool, nothing very complicated. And again, it is very key information that should be given to athlete and all members of the athlete entourage. So now we move forward to the IOC Sport Mental Health Assessment Tool. So you rely on your medical form as a sport medicine physician or health professional. You have a medical form on 3 pages. And you also have 3 forms that can be completed by the athlete form 1, 2, and 3. And why 3 athlete form? Well, it's because as a working group, we did develop the sport mental health assessment tool based on a 3-step approach. The first step is a triage step, and therefore you rely on the information provided by the athlete on the form 1. The step 2 is a more extensive screening step, and you rely on the information given by the athlete on form 2. And the step 3 is a step of intervention, of reflection, of clinical assessment on defining your management plan. And if you need some more information, you might want to ask your athlete to fill in the athlete form 3. So in the next minute, I'm just going to spend a little bit more minute on each of these 3 steps. So again, the first step is a triage step, and therefore you rely on the athlete form 1, and the athlete form 1 include an existing validated screening instrument that assess sport-related psychological distress. So you have the athlete form 1, you ask your athlete to fill in this questionnaire, 10 items. Based on the answer of each item, you can calculate a total score. Obviously, the total score, you can write it down on your medical form. And depending on the total score, then the athlete is below the threshold or at or above the threshold. Well, if the athlete total score is below the cutoff value, then there is no action needed. And if the athlete is at or above the cutoff value, then you go to step 2. The step 2 is an extensive screening step. Therefore, you rely on the information provided on the athlete form 2. And within this athlete form 2, you can find 6 existing validated screening instruments that assess mental health symptoms that are the most prevalent within the context of elite sport. So the athlete form 2 is based on 3 pages, 6 different validated screening instruments, as I just mentioned, that explore 6 different constructs, namely anxiety, depression, sleep disturbance, alcohol misuse, drug misuse, and finally disordered eating. Of course, as a professional, you still rely on your medical form on the first 2 pages. In particular, you ask your athlete to complete the 6 screening instruments on the athlete form 2. For each of these screening instruments, you can calculate the total score. You can write down the total score on the first page of your medical form. You can transcribe all the information on your summary table on page 2 of your medical form. And for each of the 6 screening instruments, you, of course, have the cutoff value available. If all the 6 instruments are below the cutoff values, then you go to step 3A. And if one or more of these 6 instruments are at or above the cutoff value, then you go to step 3B. There is one particular circumstance and one particular item within the instrument for depression. It's item number 9. If the box is ticked by the athlete on item 9 of the depression instrument, then you need to take immediate action, because this item reflects to potential thought of your athlete to commit suicide or to harm someone else. So obviously, there is no time to waste and you need to take immediate action. So the step 3A, again, if all 6 screening instruments are below the cutoff value in step 2, then obviously you can offer your athlete some brief intervention, such as psychoeducation. We heard from Caroline and Abhinav that education is very important, so you can offer him or her some education about mental health symptoms and disorders. You can offer some soft intervention, such as meditation or mindfulness or mental skill training. Obviously, you keep monitoring your athlete, and therefore you can use the athlete form 1 that assess sport psychological distress. If one or more of the screening instrument assessed in step 2 is positive, then you need to conduct a clinical assessment. And within your clinical assessment, you focus especially on the severity, complexity, the diagnostic uncertainty of the construct that was screened positive, and you look as well whether your athlete perhaps was non-responsive to a previous treatment. Within your medical form, we have tables where you can write down your findings, and there is, of course, a lot of instruction that help the medical professional in order to answer the question with regard to the severity, for instance, and complexity of the condition. If you think that during your clinical assessment you are missing some information about perhaps other constructs related to mental health symptoms and disorders, obviously you can use the athlete form 3, where you can find some existing validated screening instrument for other construct. And obviously there is also some instruction within the medical form for the cutoff value for each screening instrument. So based on your clinical assessment and also on all information gathered in step 1 and step 2, eventually information provided by athlete form 3, then you need to define your management plan Therefore, you can, of course, refer to the IOC consensus statement that was presented by Claudia Reardon, extensive document where you can find a lot of guidance in order to manage an athlete with mental health symptoms and disorders. If you feel insecure, or if you feel that perhaps a colleague professional could assist you or help you in managing your athlete, obviously you can refer him or her to clinical psychologists or to a sport psychiatrist. I mean, there is no shame to say that a particular case is difficult and complicated, and there is no shame to refer an athlete to a colleague who has a little bit more extensive knowledge when it comes to mental health symptoms and disorders. So we believe that the IOC Sport Mental Health Assessment Tool is the way to go in the future, especially when you see the ease of the three-step approach that we did selected. The triage step and the extensive screening step can be embedded in any existing and secure online platform that generally already use within the context of elite sport. We believe that the IOC SMART should be used at least in the pre-competition period, but ideally also within the mid and end season period in order to monitor the mental health symptoms and disorders of elite athletes. And the SMART should definitely be used when any significant event occur within the life of an athlete. And obviously within elite sport, a significant event is an injury, is an illness that lead to a long-term period without training and competition, a surgery as well. Unexplained performance concern is also something, of course, always stressful for any athlete. And you also have the adverse life event that occur outside the athletic environment of the athlete that needs to be monitored, and that might trigger the use of the SMART within an athlete. So to sum up, the SMART three-step approach, you rely on your medical form and 3 athlete forms. In the step 1, obviously the athlete completes the athlete form 1. You can use a medical form to decide whether someone is above or below the cutoff value. There is no action needed if the athlete is negative on the athlete form 1. If positive, then you go to step 2. For step 2, you rely on the athlete form 2. 6 screening instruments are completed. And if none of them is positive, then you go to step 3A. If one or more is positive, then you go to step 3B. Step 3A is a synonym to a brief intervention and keeping monitoring your athlete when it comes to his or her mental health symptoms and disorders. Step 3B is synonym of a clinical assessment where you need to gather all information needed in order to define your management plan, and you might want to consider to refer your athlete to a clinical psychologist or psychiatrist, and you might want to consider to gather additional information by using the athlete form 3. So the SMART and also the SMART, so the assessment tool and the recognition tool, is only the first version. So it's not a gold standard. It's neither the silver standard right now. We strongly believe that both tools will be susceptible to be updated, and the quality might be increased in the future. It's the same process that we did have with the SCAT, the Sport Concussion Assessment Tool, which is nowadays the SCAT 5. So it's our intention as a mental health working group of the IOC to increase the quality of the SMART and the SMART in the future. And that was all. I think I'm just in time for perhaps taking 1 or 2 questions.
Thank you, Vincent. Really interesting presentation, really interesting tools as well. I think well needed. And also, if I look at the chat, there are some questions about these tools. I think one question that keeps popping up, if there's any information or data on the validity of these tools.
Yes, as I mentioned, obviously, I didn't want to spend too much time on the process that we went through in order to develop the tool. We did conduct many scientific approaches in order to come to the SMART, and one of them was obviously to look at the reliability and the validity of the tool. So yes, we have data. It was actually conducted within the context of professional football. We also look whether the tool was well received among sport medicine physicians working within the context of elite sports. So a lot of processes are described within the manuscript published and freely available within the British Journal of Sport Medicine.
Okay, so likely some of these questions will be solved when people
yes,
but
obviously in the future, I definitely encourage research group to focus on the reliability and the validity of the SMART. You know, as the SCAT, we want to make it even better in the future. Yeah, I welcome all exercises that are looking at the reliability and the validity of the SMART.
Okay. Here's another question that a couple of people asked, if there's any experiences or feedback already from athletes.
Not yet. Not yet. I must say that the SMART, we try to implement it within sport context in Canada and the USA, which is already ongoing. So we might get some feedback in the future. You can imagine it was published only in September, 6 weeks ago, and available 6 weeks ago. So I think it's not fair to expect to have some feedback already right now. Within the mental health working group, obviously, we did include the feedback of athletes in the development of the tool, because some athlete and former athlete are included within our working group. And within my sport, professional football, I will strive to include the SMART as a standard screening instrument for all professional footballers across the globe. Last thing that I perhaps want to mention, if you are interested to be educated how to use the SMART, or perhaps about the whole spectrum of mental health symptoms and disorders, I want to mention that the IOC did develop a diploma and a certificate on mental health in elite sport, and it is available through the Sport Oracle website. So I think everyone who wants to be educated specifically on such topic can refer to the IOC programs.
Okay. I think 2 more quick questions. Here's one question that maybe also relate to the previous speaker, and a question there. Is this tool solely for athletes, or might it also be used for coaches or other staff members?
No, it was developed principally for athletes. That does not mean that the existing screening instrument that we did select and that are validated, they are likely to not be sport specific, and that might be also applicable to coach, but it was principally developed for elite athlete. And as mentioned in the previous talk of Alan, obviously coach and all other member and entourage are very important, and we need to focus on them as well in the future.
Okay. And finally, not so much a question, but I think more a remark from Neil Clark that maybe this could also be a useful tool to measure transitions throughout an athlete's career. So instead of a screening tool, or maybe also have it as a monitoring tool. Potentially something to look at in the future.
Yeah, good idea for sure.
Okay. So thank you all speakers for being here today. Before you all log off, I would like to share with you one more thing, and that is next episode's theme. That will be on Friday, December the 4th, same time. And we will go in leadership and management of medical teams in sports, and specifically in elite sports. And this comes out of a running collaboration with the medical support staff from some professional sports clubs that you see here. Los Angeles Rams, Las Vegas Knights, Arsenal, and also the Brazilian of the Portuguese Football Federation. More info on that will follow via our social media channels. All I can do now is thank you all for being here. Enjoy the rest of your day. And all talks will be uploaded soon, and you will receive an email if you're registered when that is done. Thank you very much.